Hello everyone, I'm Dr. Ali Bozorgi, cardiac electrophysiologist, and welcome back to our ECG Refresher. Today, we're delving into an ECG of a 60-year-old man with history of coronary artery disease and heart failure with LVEF of 15%. Came to emergency department complaining of palpitations and ECG of tachyarrhythmia and previous ECG in sinus rhythm are shown. Before we proceed, I encourage you to pause and carefully observe the ECG. Soon I'll give you an in-depth breakdown of what we're seeing. In this ECG, the first thing that catches our attention is rapid and irregular rhythm, characterized by wide complexes and heart rates of approximately 150 per minute. Now, within this arrhythmia, there is a peculiar occurrence. Certain beats exhibit wider complexes with distinct morphology. These beats. This brings us two important questions. One, what exactly is the diagnosis of arrhythmia? Is it supraventricular tachycardia with aberrant conduction, or could it be a ventricular tachycardia? Two, what about these single wide complexes with different morphologies in between? To address the first question, let's consider the patient's history of heart failure that guides us to ventricular tachycardia. However, one approach involves comparing the QRS complex of the tachyarrhythmia with the patient's baseline ECG. It's evident that the QRS complex in previous ECG matched those seen during tachyarrhythmia. You can see very similar complexes here and here in all leads. This leads us to speculate that there is supraventricular arrhythmia in patients with pre-exciting IVCD, intraventricular conduction delay. Zooming in on this ECG, we spot P waves here with 2-to-1 conduction, hinting at the potential for atrial tachycardia or atrial flutter, given an atrial rate of about 300 per minute and the characteristic sawtooth appearance in V1. The initial diagnosis leans toward atrial flutter with 2-to-1 conduction. This diagnosis was further confirmed through administration of adenosine, as you can see here. With adenosine administration, sawtooth pattern becomes more evident. But let's unravel the mystery behind those single bits with different QRS morphology. In this scenario, we have three potential explanations for these beats. One, the rhythm is atrial flutter, and these QRS are PVCs, premature ventricular contraction. Two, the underlying rhythm is atrial flutter, and those different QRSs are pre-excited beats. And three, the underlying rhythm is atrial flutter, and those beats are simply aberrant conduct. To distinguish between pre-excitation and PVCs, some key observations come to our aid. In cases of supraventricular tachycardia with pre-excitation, the degree of pre-excitation can vary. Notably, delta waves indicative of pre-excitation are rarely observed in wide complex beats in this case. Most instances of PVCs exhibit a fixed coupling interval, which refers to a time between the preceding narrow QRS complex and the initiation of PVCs. Interestingly, in this case, the coupling interval is fixed, as you can see here, favoring a PVC diagnosis, given that pre-excitation usually shows variable coupling intervals. PVC usually exhibit a compensatory pole, which is absent in pre-excitation. With these considerations in mind, our primary diagnosis points toward the presence of PVCs concurrent with atrial flutter. A closer look at the effect of adenosine administration reveals that while adenosine induces AV block, those wide complex beats continue to persist with the same coupling interval. This persistence occurs because adenosine has no impact on PVC. Therefore, we can confidently conclude that those peculiar bits are indeed PVCs. In summary, this ECG was a flutter with PVCs in between. This case teaches us the art of careful observation and significance of looking at the base ECG. It reminds us that behind every rhythm anomaly lies a story waiting to be decoded, enriching our knowledge of ECG interpretation. And there you have it. For more detailed insights, explore cardiocase.com. Case 215, elaborated upon by Dr. Hatami. Stay tuned for more ECG insights in our upcoming videos. Thank you for joining, and until next time.